Hello everyone and welcome back to another important concept. Today we shall discuss an important topic, that is paradoxical aciduria. In this video we will understand many concepts related to acid-base physiology, especially the metabolic alkalosis part, fluid and electrolyte balance and renal homeostasis mechanisms. So please watch till the end and let's begin the video. Paradoxical aciduria is a condition wherein the urine is inappropriately acidic in the setting of systemic metabolic alkalosis. This is seen in conditions associated with persistent vomiting, which is associated with more commonly associated with idiopathic hypertrophic pyloric stenosis, also called as congenital hypertrophic pyloric stenosis, which is seen in infants. So, under physiological conditions, we all know that whenever there is excess alkali in the blood, as a part of homeostasis, body tries to excrete this excess alkali to bring back the pH to normal. So, on excretion of this alkali, the urine becomes alkaline. However, in case of paradoxical aciduria, this homeostasis mechanism is altered, leading to excretion of more acidic urine. Now, what altered mechanisms will cause this? Let's understand. Idiopathic hypertrophic pyloric stenosis is a condition characterized by hypertrophy of the pyloric muscle of the stomach, leading to narrowing of the pyloric lumen and gastric outlet obstruction. This presents with severe persisting vomiting in infants, especially after each feed. Before understanding these altered physiological states, let us understand the basic physiology behind acid base and electrolyte balance. We all know that gastric juice is predominantly made up of HCl, that is hydrochloric acid, which is rich in H plus, that is hydrogen and chloride ions. Also, sodium and potassium are also present in some amount in gastric juice. The hydrogen ions secreted into the gastric lumen are derived from the breakdown of H2CO3 under the influence of carbonic anhydrates. Now, this H2CO3 is formed by the combination of CO2 molecule and water molecule, again under the influence of carbonate anhydrase enzymes in the gastric parietal cell. Now, once H plus is synthesized in the gastric cell, it is secreted into the gastric lumen. Now, chloride also enters the gastric cell from the blood. This is in exchange to the bicarbonate ion that enters the blood. The chloride within the gastric cell is then secreted into the gastric lumen, so forming the hydrochloric acid in the gastric lumen. This means that for every one molecule of H plus that is secreted into the lumen, one bicarbonate ion is added into the blood. During a meal, as there is increase in acid secretion, more H plus is secreted into the gastric lumen and hence more bicarbonate is added into the blood, which leads to a transient alkaline state, or that is known as transient alkaline tide. Now, what happens to this extra bicarbonate ion entering the blood? As the gastric juice is acidic in nature, the pancreatic juice is alkaline. That is, one bicarbonate ion enters the duodenal lumen and one H plus molecule is added to the blood, which balances for the extra bicarbonate ion that was added from the gastric parietal cell, thereby maintaining the electron neutrality. The chloride ion that was secreted into the gastric lumen is reabsorbed from the distal GIT, hence, there is no net loss of chloride from the body. What happens in case of vomiting? When the content of the vomitus is predominantly gastric fluid, there is net loss of H plus and chloride and sodium and potassium ions in the form of gastric fluid. To maintain the gastric acidity, more H plus ions are secreted into the gastric lumen, ending up in extra load of bicarbonate ions being added to the circulation. This leads to metabolic alkalosis. More severe is the vomiting, more H plus ions are lost, and more alkali is added to the blood, leading to more severe metabolic alkalosis. It is important to understand that it is the extra bicarbonate load that is added to the blood which is responsible for the metabolic alkalosis and not because of the loss of H plus ions from the body. The chloride ions that are lost in the vomitus, if not replaced orally or parenterally, leads to net chloride deficit. In case of vomiting, the following are lost from the body, that is, the water or the fluid content, chloride and hydrogen ions, which form a rich components of gastric juice. Also lost are the sodium and potassium ions, We have already seen that there is increase in serum bicarbonate levels because of the extra load of bicarbonate that is added into the circulation. So what happens to this extra load of bicarbonate which is added to the blood during vomiting? When the kidneys are functioning normally, this extra load of bicarbonate will be excreted in the urine, bringing back the serum bicarbonate levels to normal. Also, kidneys absorb more water and also decrease the urine output, thereby compensating for the gastric fluid loss. Before proceeding further, let us quickly revise the mechanism of sodium absorption from the kidneys. The sodium absorption from the kidneys mainly depends upon two mechanisms. First is the one that sodium absorption is coupled with chloride absorption. This is to maintain the electroneutrality in the tubular interstitium. This takes place in the proximal convoluted tubule, thick ascending loop of Henle, that is our sodium potassium 2 chloride transport, and in the DCT. The second mechanism is that sodium absorption is coupled with either hydrogen or potassium excretion. This takes place in proximal convoluted tubule and mainly in the distal convoluted tubule. In this diagram, we can see that the sodium absorption is either coupled with chloride absorption or H plus and K plus excretion. Under physiological conditions, sodium reabsorption is predominantly coupled with chloride absorption from the renal tubules. It is important to note here that the H plus secretion is again mediated by carbonic anhydrase enzyme, and this leads to addition of further bicarbonate into the blood for H plus secretion into the tubular lumen. We will understand its significance in our further discussion. We have seen previously that the metabolic alterations that occur during vomiting, that is, increasing bicarbonate load, is taken care by the kidneys by increasing its excretion, and also the loss of gastric fluid or the water content from the body is compensated by decreased urine output and water conservation by the kidneys. The real problem starts when the vomiting is either persistent or severe, which happens usually in case of IHPS. Now, this leads to failure of the homeostatic mechanisms, thereby leading to drastic consequences. In case of severe persistent vomiting, there is significant dehydration, which in combination with decreased oral intake due to vomiting leads to intravascular volume depletion. This will lead to decreased glomerular filtration rate, that is the GFR, which in turn leads to decreased excretion of the bicarbonate load in the urine. So whatever extra bicarbonate load was present is not being excreted, leading to persistence of metabolic alkalosis. Sodium depletion from the body is again an important event which leads to persistence and worsening of the metabolic alkalosis. As sodium is lost in the vomiters and also there is decreased oral intake, the body has to now conserve more sodium by increasing its absorption from the renal tubular lumen and decreasing its excretion into the urine. We have seen previously that sodium absorption is predominantly dependent on chloride absorption. Now, as the body is chloride depleted, it is not available for sodium absorption. Now, the body has to depend on the second mechanism, that is increasing the potassium and H plus excretion in exchange to sodium absorption. Sodium absorption comes at the expense of increased potassium excretion in an already potassium depleted child, which will further worsen the hypokalemia. There is already potassium depletion in the child because it is lost in the vomitus also. Also, for every one molecule of H plus to be secreted into the tubular lumen, one more bicarbonate molecule is added into the circulation, as we have seen previously. This will further aggravate the metabolic alkalosis. There is also significant hydrogen depletion from the body. The causes include: number 1, H plus is lost in the vomiters as it is a chief component of gastric juice. Number 2, there is loss of H plus in the urine as more H plus is excreted in exchange to sodium absorption. Number 3, there is volume depletion, hence there is renin angiotensin aldosterone system activation, which leads to increased aldosterone levels, which further increase the hydrogen ion excretion. All these mechanisms further increase the metabolic alkalosis. There is one more important concept to understand here. We all know that potassium is predominantly an intracellular ion. So whenever there is hypokalemia, as seen in IHPS, Body tries to maintain the serum potassium levels by shifting the intracellular potassium out of the cell to the blood in exchange to hydrogen ions that enters into the cell. This will further aggravate the alkalosis as the concentration of hydrogen ions from the blood decreases. Potassium depletion is also a significant problem in children with IHPS. The now causes for potassium depletion from the body include: number 1, potassium is lost in the vomiters and also there is decreased oral intake. Number 2, there is increased excretion of potassium in the urine in exchange to sodium reabsorption by the renal tubules, as we have seen previously. Number 3, with transcellular shift of the potassium out of the cell, now more potassium is available in the blood for excretion in exchange to sodium absorption. This leads to severe potassium depletion from the body. Summarizing the metabolic complications or abnormalities in idiopathic hypertrophic pyloric stenosis. Number 1, there is dehydration. Number 2, there is hyponatremia. It is important to note here that despite of body sodium depletion, the serum sodium may be normal. This is because both water and sodium are lost from the body. So as we all know that the sodium concentration or the serum sodium levels depend upon the relative concentration of the sodium with the body water content. As both are lost from the body, so the serum sodium may be either normal or slightly decreased. Number 3, there is hypokalemia. Number 4, there is hypochloremia. Number 5, we have metabolic alkalosis. So this is what is described as hypochloremic metabolic alkalosis, which is very specifically seen in case of children with IHPS. So why the urine is acidic despite there being significant metabolic alkalosis in the blood? The mechanisms we have already studied before. Just summarizing them up, there is decreased bicarbonate excretion into the urine. This is because of the decreased GFR secondary to volume contraction. Number 2, there is increased hydrogen ion excretion into the urine in exchange to sodium reabsorption, which will make the urine more acidic. Whenever we study the topic of metabolic alkalosis, we study it under the following two phases. Number 1, there is generation phase or the initiation phase, wherein there are factors which initiate the metabolic alkalosis. Number 2 is the maintenance phase. As the body has its own compensatory mechanisms to bring back the pH to normal, only when these mechanisms fail will the metabolic alkalosis persist or worsens. Most of the times, the initiating event itself contributes to the failure of compensatory mechanisms along with other factors. This leads to severe persistent metabolic alkalosis, which, if not urgently intervened, leads to grave consequences. In case of IHPS, the initiating trigger is the vomiting that leads to adding of the extra bicarbonate load into the blood. This metabolic alkalosis, which is generated, is maintained by multiple factors, which are as follows. Number 1, there is decreased bicarbonate excretion because of the decreased GFR. Number 2, there is increased bicarbonate production by the kidneys to produce more H plus, which needs to be excreted in exchange to sodium. Number 3, there is transcellular shift of H plus into the cell in exchange to potassium ions. Number 4, there is volume depletion leading to renin-angiotensin system activation, which increases the aldosterone levels, which further worsens the metabolic alkalosis. Number 5, hypokalemia per se by various mechanisms leads to more metabolic alkalosis. So how do we manage this multiple and complex metabolic abnormalities seen in case of IHPS? In fact, it is very simple. We just need to correct the main underlying abnormalities. That is, the main culprits here are volume depletion and the hypochloremia. By just correcting the volume depletion, hypochloremia, and hyponatremia, most of the metabolic abnormalities and metabolic alkalosis gets corrected significantly. Fluid resuscitation with normal saline, that is sodium chloride, provides all the three, that is fluid, sodium, and chloride. So, with fluid resuscitation, sodium and chloride replacement, number 1, the circulating volume improves, thereby increasing the glomerular filtration rate and thus increasing bicarbonate excretion. Number 2, there will not be any more stimulus for renin-angiotensin-aldosterone system activation, and there will not be any further aldosterone production. Number 3, more chloride is available now for reabsorption with sodium, so that H plus and K plus are no more required to be excreted for sodium absorption. So this will decrease the H plus and potassium depletion from the body. Fluid resuscitation and sodium chloride replacement will also take care of the potassium depletion from the body, that is by decreasing potassium excretion and also decreasing the RAS activation. Other management may include additional potassium supplementation for the treatment of hypokalemia based on its severity. Metabolic alkalosis, however, it gets corrected just by fluid resuscitation and chloride replacement alone, and usually does not require any specific treatment, and the definitive treatment being surgical correction of the IHPS. So the take home message from today's discussion is: number 1, in case of acute gastroenteritis or vomiting or diarrhea, the principal metabolic acid base abnormality depends upon which is the predominant fluid that is lost from the body. For example, if the predominant fluid that is lost is the in the form of vomiting, that is the gastric juice, which is acidic in nature, the main acid base abnormality will be metabolic alkalosis. Similarly, if the predominant fluid lost is the intestinal fluid, which is alkaline in the form of diarrhea, the predominant acid base abnormality will be metabolic acidosis. At times, things may not be so simple and straightforward. For example, a child with severe persistent vomiting will be having metabolic alkalosis. However, he may be having severe dehydration and intravascular volume depletion, which leads to decreased end organ perfusion and lactic acidosis. This lactic acidosis will falsely decrease the blood pH and mask the severity of underlying metabolic alkalosis, leading to its undercorrection. In the same scenario, this may lead to a mixed acid-base disorder, wherein child is having both metabolic alkalosis and metabolic acidosis secondary to lactic acidosis at the same time. The second important take-home message from today's discussion is that whenever the body faces a simultaneous challenge of disruption in homeostasis of both volume depletion and acid-base disorder, more priority is given by the body to compensate for volume depletion to ensure adequate end organ perfusion. This sometimes comes at the cost of worsening of underlying acid-base disorder. We have seen this phenomenon in our case of IHPS, where despite metabolic alkalosis, body is trying to focus more on restoring intravascular volume than to compensate for metabolic alkalosis or hypokalemia, ending up in worsening of both metabolic alkalosis and hypokalemia. Hope today's video was helpful. Thanks for watching. Meet you in the next video. Till then, happy learning.